Thank you very much, and good morning, everybody. Yeah, I nearly didn't make it. I was still in Reus Airport in outside Barcelona last night at midnight, so I was getting a bit worried that I wasn't going to be here. But it's a pleasure to come, and it's kind of an opportunity for me, first of all, to say thank you to Asbestos Action, and just to kind of reflect on the huge impact that the charities working together have had in developing mesothelioma services, and I'll just try and take you through some of the clinical progress that's been made and some of the research activities that I hope will give some of you some positive feelings towards what is a very difficult illness. So, as you can see there, my role is kind of twofold. I'm a professor at the University of Glasgow, but I also run the National Mesothelioma Service in Scotland. And I also serve on Meso UK's as a trustee, and I'll try and kind of reflect on those experiences as we go through the talk. If I can get the clicker to work, here we go. Okay, so I'm going to start with kind of a little bit of an introduction to where we were in mesothelioma maybe 10 years ago, and talk you through the strategy that we've taken to try and improve services. And I'll take you through what that progress looks like, and covering things like quality assurance and access to trials and engagement with charity and other sectors. And then I'll try and touch on some of the research activity. I'll try and make that as accessible as possible. And then importantly, I'm just going to try and finish with some reflection on what we're aiming for now, because we've really only started this journey in mesothelioma. So, many of you will be aware of mesothelioma and what it is, but just in terms of some basic introduction, this is what mesothelioma looks like on an MRI scan, and you can see it outlined there inside the undersurface of the ribs, and you can see the grey shadowing next to that bright white tumour is fluid, and the lung is then collapsed down next to it, and that's why patients feel breathless. It's driven by asbestos. And there's a very typical latency of 3, 4, 5 decades, which can be very hard for patients and families to understand. And about half of patients will pass away within a year, although actually it's a very diverse illness, and we can have patients that live for many, many years and others that have less time. And for various reasons, Scotland has amongst the highest incidence in the world, primarily driven by our use of asbestos in heavy industries and shipbuilding. So the figure you see there, the graph you see there, is numbers of mesothelioma cases in the UK since the kind of late 70s, early 80s. And you can see this massive rise, and that's really driven by that legacy of asbestos imports. And we don't use asbestos in the UK anymore, and the expectation is that numbers will fall. But across the world, there is a global epidemic of mesothelioma that is not started yet. So we have continued asbestos use in Brazil, Russia, India, China, Kazakhstan. So there is a global problem that will continue. And we're just starting to challenge and push back on what has been quite low investment in research. And we've made some successes, and we've attracted some big research grants to help change really what was a very depressing picture in terms of mesothelioma at the bottom of the research funding envelope. So in Scotland we have about 200 cases a year, and that's been reasonably steady for about the best part of 10 years. Most of the cases are focused around the west and the Clyde estuary for obvious reasons given what I've just said, but we do have cases all over Scotland, and for the reasons for that can be complex. We actually have a number of patients who live in the north who maybe are expats, in inverted commas, from England or from down south, and then they come up and retire, and you know, so we have a kind of diverse population of mesothelioma patients that a service really needs to try and serve. The typical kind of epidemiology of mesothelioma is the story of the shipyard worker, and so the image on the right there is in the red is the old Southern General in Govan, and so that's where I spend about half of my time. Obviously, it's now the new Queen Elizabeth Hospital, but you can see there are 3 shipyards within a mile of that building. And so that's why we have so many cases in the west. The image on the left is Greenock, and that's where I grew up, and that's where all my family still live. And so, you know, I kind of grew up around shipyards. But that's kind of changing. We have a big problem with environmental exposure to asbestos that is difficult to make accurate predictions about. We have hundreds of schools in Scotland with asbestos, and the risk of exposure to asbestos in those settings is entirely driven by how perfectly that asbestos is maintained. And we don't have a policy yet at a UK government level to actually have a programme of safe removal, which I'll come back to towards the end. So just to reflect on where we were and what we've needed to address. So the organisation of cancer services in Scotland is, for many years, has been based around cancer waiting times that you will be familiar from the news and other settings. And those cancer waiting times targets tend to drive health board funding priorities. And mesothelioma was always excluded from those targets because those targets were for the big cancers with enough patient numbers to drive priorities. And so we were really at the back of a long queue, and we were really struggling to build cases across the country to develop the specialist services that are needed. And so this slide is one that I kind of quite often show at talks, and it kind of summarises the journey of what is now the Scottish Mesothelioma Network, and it summarises kind of a decade of work from lots of different people. But I'll maybe just pick out some key points because I think it highlights some of the things I mentioned at the start in terms of how we can develop services when we work together. So we started off by developing a local service at the Southern General for Govan patients, and that was built around thoracoscopy, which is a technique where we put a telescope in between the ribs and we take biopsies. And we used a little bit of money to get that service up and running, and then we developed a regional west of Scotland mesothelioma service, and that was unfunded, and it was based really on grace and favours and cups of coffee and handshakes and thank yous and please can you come to the MDT every week, and no, we're not going to pay you. And we had fantastic colleagues that did that for the best part of 3 years, and what that did is that it demonstrated what could be done, and it also demonstrated inequity. And inequity is clearly not a good thing, but it can be a good thing if it drives change, and it can be a good thing if it raises the bar and therefore applies pressure for services to be developed in other areas. And so working with patients and families, and so it was Julie Roberts' family from Lothian, amongst other families, including some of my own patients, that came together at a meeting with the Scottish Government and with Kezia Dugdale, who was then leader of the Labour Party. And we had a roundtable discussion at Holyrood, and then we worked really with Macmillan and Meso UK to develop a funding bid, an external funding bid to support a national service, which was funded. And so we brought money into the health service to develop a mesothelioma service for Scotland. At the same time, we developed mesothelioma QPIs, which are quality performance indicators. So that means that health boards have a standard they must achieve in terms of performance, and I'll take you through some of those in the next few slides. And that service was launched on the 12th of April 2019, and that gave us money for 3 years. And we've just finished that 3-year period, and I'll kind of bring you up to speed with where we are now in the next few slides. So this is how the network was deployed. We developed a hub and spoke model, so we wanted to have clinical leads and nurses in all of their major cities. And we were able to achieve that, and we have a weekly MDT, so that's a multidisciplinary team meeting where we have a pathologist, a radiologist, a chest physician like me, a palliative care doctor, oncologist, surgeons. We all meet, we all look at the scans, we look at the biopsies, we try and work out what would be the best range of options for a patient, and then we present those options back to the local team so that the care of that patient can be delivered locally, but according to a high standard. And so that was set up with just over £1 million from really a consortium of partners that included Macmillan and Meso UK, and Action and Asbestos, but also Asbestos Action now are funding some of our nurses, for example, Susan, who's in Tayside, and that is really powerful, that combination of partners. This is what the MDT looks like. We used to meet in part physical form pre-COVID, where we had a kind of hybrid thing where people dialed in from other sites. And actually the only good thing about the pandemic was that it made us go completely to Teams and virtual, everybody's virtual. And actually that gives a much more balanced discussion. You don't have half the people who can't hear half the chat. And actually it works really well. And we've just gone through an MDT accreditation process in Scotland called MDT Fit, where we have external peer review, and we have some essentially benchmarking of our own processes, and we've gone through that just in the last few months, and it was really very rewarding. And as I've said before, what that system is about is not telling local clinicians what to do with their patient. It's about presenting an equitable range of options to local teams and empowering them to give their patient the best choices. And we try as much as possible to have the patient represented in the meeting, and we can't have the patient in the meeting, but what we have is we obviously fund nurses and lead clinicians in those sites, and we ask those people to have try and met with a patient and bring their voice and their wishes to the discussion. So we generate an outcome which is a slightly boring bit of paper, but the process is important here. It's important that those decisions are clear and documented and are transmitted back to local teams immediately. So the outcome would go back to the local teams that day, and so they would have an outcome from the MDT within about an hour. And we also explicitly prioritise trials through that process. So we will highlight to local teams what maybe the standard care options are, but we will also highlight to teams if there's an available clinical trial that we think that patient might be eligible for, and we provide an email address for the person who's leading that trial. So I mentioned quality performance indicators, or QPIs, and so these, again, these were not available for mesothelioma until we really applied pressure and worked with national cancer teams at Scottish Government to lobby for that these should be in place for mesothelioma, because what they do is they do mandate health boards to deliver, and if you don't deliver, then there's a financial penalty. And we have, through a very wide-ranging consultation process, we've developed 8 QPIs, which have been now in service for about 3 years, and they require a very high proportion of patients, for example, to come to the MDT. It's effectively 100% need to come and be discussed at the MDT. Targets for the quality of the histopathology, so that's the biopsies that are done, the access to systemic anti-cancer therapy, so chemotherapy or now immunotherapy, and access to trials and other things. We publish an annual report, and so if you go to our website, which is, I'll show you later, but you can download the report, you can see what we do, it's very transparent, you can see the areas that we're not performing in, and as I said before, inequity is not good, but inequity allows us to identify areas for improvement, and it is through auditing widely and reporting openly that we can actually identify areas that need more support so that we can bring those services up. We also have developed a national clinical management guideline, which is becoming, and this is not for you to worry about reading because you won't be able to read it, I don't think, but it's in a good way becoming more complex because we have more options. And there are various elements of the discussion of a patient that are critical, and you need specialist people involved in that discussion. You need specialist radiologists who know how to stage the disease. You need a surgeon to have a view on whether the disease could be technically removed, not because many patients will have surgery. In fact, only a very small proportion of patients should really have a discussion about surgery given various uncertainties. But the decision on whether disease is technically resectable or not does drive some of the other downstream decisions on access to drug therapies and how likely those are to work. And many of you will have heard that for unresectable disease, so that's disease that can't all be removed by a surgeon, then immunotherapy with the combination of 2 drugs has been licensed just this year and approved and funded in Scotland. And so that approval process, again, we were able to influence that process by working together, by working with clinicians and patients and charities, including all of us here, to try and apply pressure, because pressure matters in this situation, because these funding decisions are, to some sense, about money, and so you have to make an argument. So this is the data that has got many of us more optimistic than we maybe were around drug therapy for mesothelioma. So this is called a survival curve, and so it's the way we measure the effect of medicines we give to cancer patients. And unfortunately, what the curve shows is the numbers of patients who are still alive and well as time goes on. And obviously, if you give a drug therapy, you want to see more and more patients who are still alive and well. And obviously, the higher up the curve is, the better you're doing, the better the medicine is. And so the 2 curves show in blue the new treatment, which is a combination of nivolumab and ipilimumab, which are 2 immunotherapy drugs. And the red curve is the previous standard of care treatment, which is chemotherapy. And you can see there's a very big difference. And this is in patients who've got a certain subtype of mesothelioma, non-epithelioid mesothelioma, which traditionally actually we have very few options for that are effective. So that is very positive news. And with the SMC approval that was published in February, what that now means is that if your doctor feels that that combination of medicines is suitable for your kind of mesothelioma and for your overall profile, because these drugs are not easy. It's not a walk in the park, these 2 drugs. They have significant side effects. But you should be able to access that treatment free within NHS Scotland. And Scotland led the way in that licensing, and actually NICE, thankfully, have just matched that decision for patients in England and Wales, but there was a strange period there for about 6 months where we were getting patients from down south contacting us, asking if they moved to Scotland, could they get immunotherapy? But thankfully that situation has gone away. I was just going to mention a couple of other things that the network is able to provide, and that one thing is a website. And so the internet can be a scary place when you have a cancer diagnosis, especially a rare cancer diagnosis, and naturally people want to go and find out, inform themselves. If you do want to do that, then I advise you to either go to our website, which is here, or go to the Meso UK website, which is an excellent website, and we link across to that. There's lots of resources there around symptom management and trials and what the whole situation means. We've also got a Twitter feed, so if you are Twitter active, or you've got maybe family members who are Twitter active, then we try and keep that up to date in terms of what's happening. You can also go and find who your mesothelioma nurse specialist is in your region, and there are contact details there, so you can make direct contact with the team. And Carolyn McRae is here. Carolyn's our lead mesothelioma nurse, and she's up the back there. She'll wave, so go and grab Carolyn at lunch or at coffee, and Carolyn can kind of direct you if you're not a website kind of person. We also offer virtual support groups, which are hosted with the support of Maggie's in Inverness. And these are safe spaces really for patients and family members to kind of share their experiences, and they're designed to kind of provide support. It seems very obvious, and the discussion really can be driven, and often is driven, by the patients and the families who attend, but is facilitated really by one of our nurses who'll be there to answer questions and offer help. And so those happen on the first Friday of every month. And again, you can find directions to those via the website. We also have an annual patient and carer day. So it's an educational event as much as anything else. And we have done those for the last 3 years. And they cover a range of topics, which can include some of the medical stuff, but can also include some of the legal issues, compensation, symptoms, mindfulness, lots of other topics we've had. And if you've missed those, you can go to our website, and all the videos are there from the previous events, so you can just dip in and out of them if you want to do that. And for clinicians, for doctors and nurses, and other allied health professionals, we also run education days to try and make sure that those who are looking after our patients are as well informed as they should be. So we run education days separately to the patient days, which are obviously more clinically focused around some of the practical issues and the challenges. And again, all those talks, if you want to dip into those talks, they're not password protected or anything. You can go and look at those if you want. And there's trials and other things in there. We also have taken the view that sharing and using the data that we collect is very important, because in a rare cancer like mesothelioma, one of the challenges actually is knowledge and knowing how best to treat patients, and even some simple things about how we stage patients, what are the best measurements to make to work out how far disease has spread. And so we've gone through I won't bore you with the painful processes that are required to share data in a kind of safe way. Obviously, you'll be reassured that there are those painful processes that we have to go through to share your data, but they do make these things quite difficult. And so we've done that, and so we've contributed Scotland's data both to the global staging effort run by an organisation called ISLC, and we've prepared that data for the UK-wide audit data when that is up and running again. So we have also been fortunate to receive some positive feedback for the service. So we won an Innovation Award at the Scottish Health Awards with, you can see Jason Leach there. We're all sick of Jason Leach, aren't we? He's everywhere. But you can see Jason Leach there on the bottom right giving that award to. So Phil, in the middle is Phil Reid, who's the Lothian lead. So he practices in Edinburgh and does mesothelioma in Edinburgh. And then it was very appropriate that Julie Roberts, who was the patient, who was the daughter of one of our mesothelioma patients, and also the niece, her uncle and her father both had mesothelioma in the same year. So Julie was very instrumental in getting some of that engagement with our politicians to get the service up and running. So Julie was able to go along and pick that award up with Phil. And so we really, towards the end of the start of this year, we're really kind of just looking for sustainable funding to try and keep things going. And we have actually been able to do that. There's a kind of slide missing there, but essentially we are now business as usual within NHS Scotland. So the service has now been embedded within the new Scottish Cancer Network, which is part of National Services Scotland. So all of the things that we do are now funded as part of the NHS. And so again, that just emphasises, I think, the way that working together we can actually build services and then make the case that they need to be supported indefinitely by government. So that has been a very successful journey, and I think it's really through the teamwork that we've talked about. I wanted just to finish with just some reflections on research and maybe some future directions. I mean, I mentioned that research investment has been lower in mesothelioma than in other diseases. We've, with my other hat on, with my academic hat on, we're very keen to understand how mesothelioma develops after decades of what appears to be benign inflammation in the pleural space, which is the lining of the chest. And if we could understand that, then we would almost certainly be able to drug the disease more effectively. And so we've been successful in developing this network, which is called Predict Meso, which is a pan-European network, which is funded by Cancer Research UK and its partners in Italy and Spain. And so they have provided about £5 million over the next 5 years to allow us to deliver a kind of integrated research program. There are 5 work packages in the middle there, where we're collecting tissues across Europe. We're doing lots of preclinical research, lots of laboratory research to understand some of those processes, screen cells and other tissues for responses to drugs. And ultimately, we hope at the end of that process to have some new treatments to offer patients in trials, not drugs to give on the NHS, but some new trials to offer. So I'll just finish with just some reflections and just maybe where we're heading across the kind of clinical space and maybe the research space with that. I think we have made quite a lot of progress, and I think in discussions across the UK, the model that we've chosen to pursue is one that I think other parts of the UK are now going to try and adopt. And I think there is learning that we can share, and a lot of that is down to partnership working with charities like yourself. We have got better treatment options, and first-line immunotherapy can be transformative for some patients, and that's something to be very positive about. We do have some challenges really around implementation, as you can imagine, and transitioning to a new home in the Scottish Cancer Network and maintaining quality, but I think we're in a good place to do that, and we've got really good synergy between the clinical and the research sides, and I think that puts us in a good place to make some of the next steps we need to do to actually tackle the disease more effectively. I think the final bullet point there is kind of a big thing. I think it's interesting to hear from our MSP colleague earlier. I think we do need to continue engagement with our political colleagues to try and make some sort of logical plan for safe removal of asbestos, because until we do that, we are beholden to maintenance budgets in our public buildings to keep many of our people safe, and I think we do need some sort of plan to tackle that in the longer term. So I'll just finish with some acknowledgements to lots of people, and I'm happy to take any questions if there are any.
Hello. Kevin, just to reflect on the journey, the progress that the network has made, in some ways there was a bit of a postcode lottery in the past when it came to access to the latest information, latest treatments, care, and levels of support. Do you think you're there in terms of the hub and spoke network in Scotland in terms of resolving that, or is there still some ground to be made?
I think that I think the first thing to say in terms of services before the network, I think that we have always had incredibly committed and caring clinical teams looking after patients. I think the issue, the lottery element, has been that the variation that did exist and does still exist, to answer your question, reflects to some extent the familiarity that an individual team might have with a rare disease. And in some areas there's more familiarity and in others there's not. And therefore there is a natural slight difference in pace of things and uncertainty and confidence, and a slight difference in awareness. And I think that the role of the network is to try and support those teams to all have the same level of awareness. And the problem is that they also need to be aware of lung cancer and COVID and lung fibrosis and lots of other things. And so we need to provide them with support, and that with nurses and clinical lead funding, we can do that. I think things like the quality performance indicators are critical for us measuring our performance and being honest about when we're not doing well enough. I think we need to be comfortable enough to share our data openly, and you know, if you don't measure, it's easy to think you're doing okay. You know, I think we do that in lots of walks of life, and you know, when we measure our own service, it's always sobering to see that, you know, the reality of how quickly you do things, or you know, the numbers in X and Y. So I think I don't think we're there yet. I think we're in a position where we can start, is what I would say, and that we have an environment in which we can look after patients better, but it's not we're not over any finish lines, I don't think.
Anybody else, any questions? One more?
I've actually been really impressed. I was diagnosed just in October, and I've been really impressed by the access to services for what is a very rare disease. My question is about access to clinical trials in Scotland. I know there aren't many at the moment, but you know, you're obviously through the work packages hoping to bring more clinical trials. Is there an issue, is there going to be an issue in Scotland having equity for people living across different regions getting access to clinical trials?
Yeah, it's a really important question, and it's a difficult challenge. So there's I think there's two kinds of challenge there. One is the challenge of actually bringing clinical trials to Scotland, those trials can either be driven by pharmaceutical companies, and often we're kind of competing with other parts of the world to try and attract those companies to come and test their medicines here. And that brings lots of advantages to patients, because we then get access to those drug therapies early. I think the network puts us in a good place to be attractive, because we're organised, we've got data, we can help them do those studies. I think the other problem, which in some ways is harder, is one of geography, because the practicalities of running a clinical trial mean that there's a lot of paperwork involved, there's a lot of admin, there's a lot of cost to set up sites. And so what we found is that trials will either be set up in Glasgow or Edinburgh, and rarely both, and quite infrequently in Raigmore. Aberdeen has done lots of trials over the years as well. But it can be difficult to make travelling for a trial easy. And Meso UK will support patients to travel to trials. And I don't know if Liz wants to comment on that, because she probably will be able to give more input than I would on that. But I think we do need to try and enable trial participation a wee bit more, and that might be by doing trials differently, by demanding less in terms of having to see you every month, do things remotely, do things using routine data, technology. So we are trying to tackle those things, but they are difficult. Yeah.
Great, thank you. No more time for questions, so as we keep on time, thank you very much, Professor Blyth.